Hello, and welcome to Addressing the Hyper in Hyperkinetic TD and Dyskinesia. My name is Dr. Laxman Bahroo. I'm the director of the residency program, as well as the director of the Botulinum Toxin Clinic and associate professor of neurology at MedStar Georgetown University Hospital. It is my pleasure to be here to present this topic to you. Let's talk about tardive dyskinesia. Tardive dyskinesia occurs typically, we think, because there's a blockade of dopamine receptors. By blockading these receptors, we create one of two possible outcomes. We blockade these receptors and create a drug-induced Parkinsonism, which we're familiar with, but is not a hyperkinetic movement disorder, or we cause these receptors to become upregulated. As these receptors become upregulated, they become more sensitized, and we see an increased amount of involuntary movements. Typically, we tend to see more tardive dyskinesia with high-potency antipsychotics, as we also see drug-induced Parkinsonism. Lower potency antipsychotics will have less of this issue, but typically they're used much more commonly. In fact, lower potency antipsychotics tend to be used much more commonly and may have a variety of other interactions with muscarinic receptors, histaminergic receptors, and even alpha-2 adrenergic receptors, resulting in issues with cognition, dry mouth, sedation, weight gain, and even orthostasis. We look at tardive dyskinesia. It was first described in the 1950s with the advent of antipsychotics. It took approximately a decade for tardive to be accepted as a potential medication reaction. The reason for that was because the neuroleptic class caused such a huge, tremendous gain in terms of improvement in the functioning of psychotic individuals and resulted in deinstitutionalization. Because of this, people were reluctant to blame the tardive dyskinesia on antipsychotics. Incidentally, if you look at it, the most common and most potent dopamine receptor blocking agents are usually the first generation antipsychotics, Haldol being the most commonly used one, and the generic name for that Haldol is haloperidol. If we look at tardive, we should really look at tardive as a spectrum of medication-induced movement disorders. I think it's important to really appreciate that tardive is a late onset reaction, but there are other drug-induced movement disorders that also occur in acute to subacute time period and over a longer period of time, which occurs in months. So anything that has the term tardive to it is occurring much later. Anything that occurs acute and subacute can occur over days to weeks. If we look at the phenomenology of tardive syndromes, and I want you to think about tardive as tardive syndromes because there's a collection of them. Tardive dyskinesia is one component of it. And we can classify these syndromes in a variety of different ways. We can classify them by what they appear like, tardive Parkinsonism, for example, tardive chorea, tardive dystonia. It can also be tardive tremor or oromandibular dyskinesias. It can also be tardive akathisia, which represents a restlessness or myoclonic issues, or such as rigidity and hyperreflexia. So tardive syndromes is really an umbrella term. Tardive dyskinesia makes up a chunk of that term, but tardive dyskinesia may cross boundaries, such as it may be oromandibular dyskinesias with some dystonic features, choreiform features, along with other things. And you may see some mixed movement disorders, which hyperkinetic movement disorders, such as the tardive syndromes, mixed with Parkinsonism. Let's talk about who's at risk for these issues. Well, individuals with older age or higher risk, presumably because they've had a longer duration of being on antipsychotics. Women are at higher risk. Individuals who have mood disorder are also at higher risk for reasons we fully do not know. But individuals who have cognitive issues, brain injury, are uniquely more sensitive to it. Typically, as we talked about, first generation antipsychotic individuals are much more sensitive to it than second generation antipsychotics. But individuals who have a family history of somebody developing tardive, or individuals who have a issue with regards to a drug-induced movement disorder preceding tardive are also more sensitive to this. If we look at the prevalence of TD, we come across an interesting event. With the advent of second generation antipsychotics, we're actually seeing less in numbers of tardive. But this, I believe, is not truly there. While we're seeing less numbers, because second generation antipsychotics are less associated with TD than first generations were, the second generation drugs have a much broader scope. They have a much larger population that can be exposed to it. Individuals that are treated for bipolar disorder, refractory depression, insomnia, and a whole variety of other off-label issues, which expands the population that is exposed to second generations, whereas the population with first generations was much more restricted, even though the numbers of tardive in those individuals was much higher. So let's talk a little bit about the etiology of TD. When we think about this, the most common class of medications that can be responsible for TD is the first generation, second generation antipsychotics. Even in that, the more potent first generation, second generation antipsychotics are more likely to be involved. Haloperidol, risperidone are more likely to be involved in this than less potent medications, such as clozapine. However, antipsychotics aren't the only class that are responsible for this. We really need to look at antiemetics, such as metoclopramide or chlorphenazine. We need to look at antidepressants, and some antidepressants, specifically the TCA class, may be associated with this because they may have some blocking activity with regards to dopamine. But there are other medications, such as lithium, that we need to be aware of. Anticholinergics can certainly worsen TD, along with antihistaminergic drugs. So it's important for us to really understand this and understand that TD, while typically associated with antipsychotics, really has a much wider range of medications, and even some anticonvulsants have been brought into this as well. If we look at the diagnosis of tardive, the interesting thing about diagnosis of tardive is that it's a DSM-5 diagnosis. I think many people forget that many times when we're dealing with neurologists and movement disorder specialists. It's defined as involuntary athetoid and choreiform movements, generally involving the tongue, the lower face, and the jaw. But it can involve the extremities, it can involve the trunk, and it certainly can involve other areas of the body as well. And people have even noticed issues with regards to dysphagia, as well as chronic hiccups have been associated as part of the tardive syndrome. The most important thing to understand about tardive is that it's later in onset. In fact, the time criteria has been loosened by DSM-5 compared to other previous DSMs. And it's important that we understand that tardive is persistent, that not only does it result from exposure to dopamine receptor blocking agents, not just neuroleptics as we discussed, but also that it's persistent even after the offending agent has been discontinued. So in general, we tend to think of tardive as occurring typically months to years, and that's true, but there is literature out there that says that tardive can develop with shorter doses, typically high-dose antipsychotics used in a more vulnerable population of elderly individuals can produce tardive in a much smaller amount. And that's how I would classify tardive. Tardive is one of those phenomenological events that you can see tardive, and it looks different from other drug-induced movement disorders. One of the most important things that we'll talk about as we talk about therapeutics with regard to tardive is the AIMS score, the Abnormal Involuntary Movement Scale. And score divides up into multiple areas. Total typical about 7 questions can be done, different body parts, involving the upper face, the lower face, the jaw, the tongue, neck and trunk, upper extremities, and lower extremities. It's rated on a 4-point scale, going from no movements being 0 to 4 movements being severe persistent movements across the entire time the patient is being examined. If you look at the treatment with regards to tardive, there may be some thought process on what we can do in terms of treatment. There's a broad ideas of treatment. Well, we have agents that are now approved to treat tardive, namely 2, valbenazine and deutetrabenazine. We're going to talk about both of those in more detail. But realistically, there have been other options considered. And if you were to look at the 2013 evaluation of issues with regards to tardive and how to best manage it, there was nothing that gave you level A. Now we have 2 events that have level A because they've been studied specifically for tardive, showing the safety and efficacy of the medications in treatment of tardive. In past, individuals have considered switching from one first-generation antipsychotic to a second-generation, or switching from a more potent dopamine receptor blocking agent to a less potent dopamine receptor blocking agent. While it's been thoughtful to do that, there has not been really any robust data indicating that. Other ways to treat tardive have been using benzodiazepines. Ginkgo biloba has shown some effectiveness, as well as botulinum toxins specifically for focal tardive, involving one specific issue such as jaw dystonias or neck postures or limb postures or even blepharospastic tardive. For the individuals who are refractory or have severe tardive, deep brain stimulation has also been shown with globus pallidus interna stimulation for individuals who are refractory to medications and even botulinum toxin injections. If you look at the AAN's guidelines in 2013, you can see there was nothing level A. Well, the same group met in 2018 and revised those guidelines and put valbenazine and deutetrabenazine as level A evidence. And I think that's important for us to consider how things have changed, that from the 1960s, into the early 2010s, there was almost no significant change in terms of recommendations with regards to tardive, and most of those recommendations did not pan out, such as changing antipsychotics, going to a less potent drug, potentially discontinuing the drug even, to now being able to have 2 level A evidence. And I think that's important for us to understand how medicine evolves and how research and therapeutics have evolved over the course of time. Let's look a deeper dive at the VMAT2 inhibitors. Now, there are 3 VMAT2 inhibitors we'll talk about: tetrabenazine, valbenazine, and deutetrabenazine. Now, keep in mind, tetrabenazine is considered the progenitor of VMAT2 inhibitor. And I think that's interesting. We'll talk about the pharmacology behind tetrabenazine or VMAT2s in a few slides. Tetrabenazine was the one that was first studied for tardive, and the studies were done either in smaller placebo-controlled trials with a very few number of individuals, as you can see, or placebo-controlled trials, again, with very small population, but not necessarily follow along as a study would. But tetrabenazine also created some limitations. Individuals had difficulty tolerating tetrabenazine because of drowsiness and fatigue. There's also the potential for drug-induced Parkinsonism that was also there. And so tetrabenazine's discontinuation rates were quite high, nearly about 23% due to adverse events. But at the same time, this also showed a window into the fact that VMAT2 inhibition could be used to potentially reduce tardive. If we look at the current VMAT2 inhibitors that are approved for it, deutetrabenazine and valbenazine, there's some similarities. The mechanism of action is similar. The dosing, as one can see, is different. The dose ranges are different. Valbenazine's dose range from 40 to 80 with a newly approved 60 milligram dose. And deutetrabenazine's dosing is much broader range. Maximum recommended dose is 24 milligrams versus 80 milligrams for valbenazine. Half-lives also make a difference. Deutetrabenazine is a twice-a-day drug, whereas valbenazine is a once-daily drug. Both are metabolized by the liver, slightly different enzymes. And of course, it's important for us to be aware of individuals who have hepatic impairment that deutetrabenazine is contraindicated, whereas valbenazine is only contraindicated in individuals with severe hepatic impairment. The way VMAT2 inhibitors work is by blocking basically the vesicle monoamine transporter and reducing the amount of dopamine that's filled into the vesicle that is then released into the synapse. By making the dopamine vesicles dopamine poor, they are reducing the overactivation and the commingling of these dopamine molecules with those hypersensitized receptors. We learned early on that downstream management of dopamine receptor blockade was not helpful. In fact, that was the culprit. And in the past, people used to treat this with increasing the antipsychotic medications to block more of these hypersensitized receptors. And in the short term, the strategy worked. However, long term, it failed because the dopamine receptor simply became more hypersensitized and ended up resulting in reemergence of tardive at a more severe amount. So downstream blockade does not work. Here, we're simply reducing the amount of dopamine released into the synapse by reducing the amount of dopamine that's packaged into the vesicles. Okay. Let's do a deeper dive into each of these 2 medications. If you look at deutetrabenazine, there are 2 major studies, the AIM study and the ARM study. Let's look at deutetrabenazine with regards to the AIM study. AIM study was designed to see how deutetrabenazine treated in tardive dyskinesia. It was a placebo-controlled trial, phase 3. And if we look at the AIM study, a couple of interesting things point out. We see the reduction with regards to the AIM score in sequential groups of individuals on deutetrabenazine. We see a 12 milligram group dose, for 24 milligram group dose, and a 36 milligram. You see a reduction in the AIM score at higher doses, with the 12 milligram dose really giving you the least reduction, barely separating from placebo, but 24 and 36 giving you a bigger reduction in the AIM score. What's also important is while we see a reduction in the AIM score, we don't see a large increase in terms of adverse events between the placebo group and the 36 milligram group. So it's important for us to take the study and utilize the study to be able to maximize our individuals with tardive and reduce their tardive symptoms as much as possible without just starting them at 12 milligrams and keeping them at 12, really going beyond 12 milligrams to find the dose that's right for them that reduces their tardive symptoms as best as possible. Here's data from the ARM study. And if you see the primary endpoints in this was reduction of the AIM score, which is what I brought up. And AIM scores are standardized and can be checked. In fact, what's important is that the AIM scores are actually mandated by some state institutions to be checked on individuals prior to starting antipsychotic medications and then checked periodically in 3 to 6 month intervals, maybe even annually in low risk patients. So here we're seeing a reduction in the standardized score that you can see in a blinded placebo-controlled trial between the placebo group on deutetrabenazine and the active group, and is statistically significant. Here we're looking at the ARM study. We talked about the AIM study previously. The ARM study was important, as I mentioned before, about looking at placebo versus active drug of deutetrabenazine. What's interesting about this study is that it shows the adverse profiles, and it shows the lower rates of psychiatric issues with regards to anxiety, depression, and suicidal ideation. This is important for us to understand because these are individuals with pre-existing psychiatric histories that are at risk for suicidal ideation or depression. And this shows that the medication, while treating tardive, is not worsening their underlying psychiatric disorder or worsening the risk of suicidal ideation. What's equally important is to understand that despite reducing the amount of dopamine in the synapse, there was no worsening of Parkinsonism as evidenced by the Unified Parkinson's Disease Rating Scale. Now let's look at valbenazine. We do a Connect3 review, and you can see Connect3 had 3 arms to it. The 6-week portion of it had a placebo-controlled arm, a 40 milligram arm, and an 80 milligram arm. Individuals are divided between the 3 groups, and the placebo-controlled group, you can see, almost has very little reduction on the AIM score. Again, same AIM score was utilized. 40 and 80 both see a reduction as early as 2 weeks, and then 40 and 80 really separate from each other by about week 4 and then continue on to week 6, with 80 giving you a bigger reduction than 40. If you look at the differences in terms of AIM scores and the tardive, you can see the improvement tends to favor going further along. In other words, I think individuals, when they start either valbenazine or deutetrabenazine, the longer they stay on it, they stabilize over the course of time of being on these medications. At the same time, the higher doses are showing a bigger reduction in the AIM score as well. Now, keep in mind, since we've talked about this, the most newest information about valbenazine is that there's a 60 milligram in between dose between the 40 and the 80 that was studied. Let's switch gears a little bit now, talk about Huntington's disease. We're going to talk about Huntington's chorea. First HD was a trial that looked at Huntington's chorea functional scores. 90 patients were evaluated. And if you look at the data with regards to deutetrabenazine, we looked at the chorea scores in individuals and found that the chorea scores improved in those on deutetrabenazine versus those on placebo. And I think that's an important point to see this medication in a vulnerable population of Huntington's patients who have a lot of cognitive impairment and are able to take a medication BID, whereas they may not be able to take medications TID that may have less tolerability issues. So I think deutetrabenazine reduces the frequency of dosing while providing a reduction in chorea, and at the same time is able to do that, and you're able to get benefit and titrate easier than having not as many side effects with a TID or QID medication. Let's talk a little bit about the other hyperkinetic movement disorder, probably the most common one we're going to talk about, which is dyskinesias and Parkinson's. And if you think about dyskinesias and Parkinson's, the mechanism is different. So far with tardive, we've talked about hypersensitized dopamine receptors. With regards to Huntington's, we've talked about degeneration of the indirect pathway of the basal ganglia. Here, this is an interesting mechanism. Here, we're actually giving individuals dopaminergic medications, but that's only part of the thought process behind dyskinesias and Parkinson's. Here, we're really looking at altering glutaminergic and dopaminergic interaction with each other. As we know, the basal ganglia receives input from multiple neurotransmitters. The most important that we think of in Parkinson's is dopamine, but the glutaminergic input from the cortex cannot be minimized. So we really have 2 different inputs. We should think of this as a competing mechanism of 2 different inputs that stimulate the basal ganglia. In other words, to fully give input into the basal ganglia, we have the input from the substantia nigra, that's dopaminergic, and the glutaminergic input. And the 2 must exist in balance to have balanced movements of on and off. When the movements are out of balance with a hyperactive dopaminergic input with a hyperactive glutaminergic input, you're more likely to have dyskinesias within Parkinson's. With hypoactive dopaminergic input, but continued hyperactive glutaminergic input, you're more likely to have offs and severe offs. So this is an important point to understand that individuals with Parkinson's, we really need to modulate more than just dopaminergic receptors. That glutaminergic receptor, specifically the NMDA receptor, is very important. And because of degeneration of the basal ganglia, the glutaminergic receptors, the NMDA included, become upregulated. Let's take a look at LIDs, levodopa-induced dyskinesias. And if you can see, levodopa-induced dyskinesias can occur at several different times. They can occur at the onset of medication when the medication response comes in. It can occur at peak when the medication response is at its highest. And again, when the medication response is dropping. So we have different types of dyskinesia based on where there are medications. So we understand that dopamine plays a role because we give dopaminergic medications, but glutaminergic signaling also plays an equally important role in this as well. So who is at risk for LIDs? Well, individuals that have young onset Parkinson's, they will have a far longer progression of disease. Individuals that have had Parkinson's longer, 5 years, 10 years, 15 years. By the time you get to a decade with Parkinson's, 80+% of individuals will have levodopa-induced dyskinesia. Individuals with higher doses of levodopa certainly are at risk. So we tend to see LIDs in individuals that are younger onset, longer course of disease, more severe disease, those requiring higher dosage of levodopa, and individuals who are used to more pulsatile formulations. For other reasons, women and those individuals with smaller body frames are also at higher risk for developing dyskinesias and earlier dyskinesias. If we look at dyskinesias and dystonias in Parkinson's, we tend to see multiple patterns. Some individuals will develop dystonias when the medications are off. They may develop dystonic dyskinesias when the medications are higher. They may develop dyskinesias of any particular body part involving dyskinesias of the face, such as eye blinking and facial grimacing. They may involve dyskinesias of the trunk with neck movements and truncal movements, as well as limb movements. So dyskinesia can affect any part. And the dyskinesias have actually been also described in atypical MSA involving facial dystonias and feet dyskinesias in individuals as well. So dyskinesia can affect any part of the body. So sometimes it's helpful if somebody has a hemidyskinesia, it's less likely that it's a medication only, but it may represent some structural changes as well on top of things, like any other aspect of hemidistribution in neurology. If we look at treatment of dyskinesias, well, in some ways, treatment of dyskinesias really brings us to a tipping point in how to manage Parkinson's. Prior to the advent of dyskinesias, we've really worked very hard to try and maximize dopaminergic medications, minimizing symptoms as much as possible. Once we've hit levodopa-induced dyskinesias, we now find it difficult to advance the medications further, even though the patient may need medication adjustments because they're having offs. Here, we've kind of hit a roadblock when it comes to this issue. So we have several options we can consider. Well, first option is, can we lower the medications? Sometimes it's possible to lower medications, many times it's not. Can we make the medications more frequent? And that may be a possibility as well. Keeping the total dose the same, but increasing the frequency, it's called fractionation of the dosing. So taking more frequent doses and smaller doses, but the total daily dose of levodopa is the same. If you look at it, the other options are to go to longer acting formulations. We certainly have newer emerging formulations of longer acting levodopa along with dopaminergic medications. So another way to do this, we have certainly surgical options to consider. And another option that's not dopaminergic is NMDA receptor modulation. I think that's an underutilized option in levodopa-induced dyskinesias because so much of our dialogue with regards to Parkinson's and dyskinesias is focused on dopaminergic medications that we reach for dopaminergic changes first. If dopaminergic changes are not working and simple changes are not working, rather than continuing those, we should look at NMDA receptor modulation because it's a non-dopaminergic target that is less utilized. Let's take a look at the evidence with regards to amantadine. Amantadine has been around for a significant amount of time and has been utilized with Parkinson's with different components of this. However, what's interesting is even earlier amantadine studies found about a 24% reduction in total dyskinesias. One of the limitations with these studies was that the studies were not all consistently done. For every study that showed reduction with amantadine, other studies did not show that reduction. For studies that showed good benefit, other studies showed that there was limited benefit over the duration of time. So the amantadine studies really gave us a signal into modulating NMDA receptor activity, but it didn't give us a clear enough signal to utilize it. However, what became interesting is that amantadine changed over the course of time. Amantadine originally that started as an antiviral medication was used for Parkinson's, has really found a niche in Parkinson's. Well, it found a niche with regard to tremor, and it's an interesting component because we utilize it for tremor predominant Parkinson's to see if we can reduce the excessive tremor. It's found its use even in other hyperkinetic movement disorders and so-called mixed movement disorders when a patient has hyperkinetic movements with hypokinetic movements. an example of somebody that has hypokinetic movements, and hyperkinetic is somebody with Parkinson's disease, which is a hypokinetic movement disorder with dyskinesias. So I think that's very interesting. We have long-acting formulations of amantadine, which have been specifically studied for levodopa-induced dyskinesias. What's interesting is for immediate release, we tend to typically dose between 200 and 300 milligrams of amantadine using BID or TID dosing, but at higher dosing, tolerability becomes an issue. And some of the side effects that we have to be concerned about are issues with regards to dry mouth, sedation, confusion, and even hallucinations. So if you look at immediate release, as we mentioned, there have been some studies that have shown a signal towards reduction of dyskinesias. How robust are these studies? How conclusive are these studies? Were all matters of debate at that point. But we know that amantadine immediate release works for tremor and has the potential to work for dyskinesia as well. One of the biggest limiting factors was being able to tolerate the dosing, specifically higher than 300 milligrams. 200 was typically the dose, 300 possibly. Enter into this amantadine extended release, and there were several studies done on this. EASLID 1 and 3 come to mind, as well as long-term extension data with regards to EASLID 2. What's interesting about this is this actually quantified the reduction that we see in dyskinesias. We actually have a unified dyskinesia rating scale that showed a reduction in terms of dyskinesias from placebo versus active drug, which is amantadine extended release. In addition to that, it also gave us an idea of the reduction in terms of time. The amount of time individuals spend in dyskinesia reduced significantly, resulting in an improvement in what's called good on time. Not only did amantadine extended release show a reduction in dyskinesias, both in terms of time as well as the amount of dyskinesias that they had, but it also showed a reduction in OFF. Something that's interesting that none of the previous therapies that I mentioned, dose fractionation and other things, reduction of doses, do not do. So on this next slide, we see the improvement not just in the dyskinesias that I just mentioned, but we're seeing an improvement in the reduction of off time, as well as overall improvement in on time with regards to amantadine extended release. And of course, side effect wise, we're seeing some of the same side effects that we expect to see with amantadine immediate release, but we're really seeing more robust information with regards to reduction of dyskinesias. And not only that, but also longer duration response with regards to amantadine extended release in the management of dyskinesias. Amantadine extended release tablets have different pharmacokinetics than immediate release. One important thing is to note that this medication is actually taken at bedtime. And by taking this medication at bedtime, the medication allows to slowly release towards the early morning, and in preparing the individual for taking their morning doses of levodopa, which may result in dyskinesia. So it controls dyskinesias over the course of the day. It is a 24-hour profile. And the important thing is, as the medications start to rise of amantadine in the system, it allows you to be able to manage the dyskinesia. And by being able to give a larger dose at one time, we're able to reach a threshold where dyskinesias can actually be managed. Look at the side effects of extended release amantadine. Many of them are similar to the side effects that we talked about immediate release. We talked about nausea. We talked about dizziness or lightheadedness, dry mouth. We typically talked about issues with regards to hallucinations. And I think that's incredibly important to have a dialogue with patients with Parkinson's who may be at risk for developing hallucinations about the expectations of starting amantadine, the benefits of starting amantadine, and what to do if they develop any of these side effects, and how to be able to mitigate or manage these side effects. I think amantadine is an interesting tool in our armamentarium, even in light of the side effects, but I think it's important for us to understand that amantadine is a non-dopaminergic drug that really has a role to play in patients who have dyskinesias. So it's important to have that conversation of the benefits of amantadine with the potential side effects of amantadine to really have the patients decide whether this is an option they want to pursue, and if they have side effects, what to do next. Thank you very much for your time and attention. I hope you found this session very informative.